All right. I've said it, I mentioned it on Kyle's podcast because, normally we keep things pretty linear. But I'm like, I don't really know what episode this is because I don't know how it's going to come out.
Yeah.
Because I think I'm almost done. I did Heather, I did Kyle, and then there's you, and I'm essentially done with Heather. So Heather will probably come out next
Before.
and then you and I, and then Kyle.
Yeah.
So
We got to give the people what they want.
yeah. So welcome back to the podcast, whatever number this is.
We don't know.
Yeah, we don't know, and we've been gone for a while.
2 months?
Yeah,
Maybe a little bit more.
About 2 months. Well, and I said it on the other podcast, but I mean, I think historically we go out of our way to make time to do this all the time. And that was just those 2 months. There was just nothing.
There was none.
Yeah, nothing. Because I had the art line class.
You did multiple Artline presentations.
Yeah.
We had
The
the
ventilator
mechanical conference after that.
Yeah,
We
Kentucky.
were gone on a trip, and then
We had one scheduled.
had one scheduled. Illness,
Got sick.
had to reschedule, and then trying to get our schedules to align to, and it's not even like get our schedules to align, to where it's comfortable for the both of us. That's not the case. Both of us will work around getting this done. It was literally like there
was no time. There
because
was
people
nothing.
give me a hard time in the ICU, same as you. I know people have been asking when are you gonna put out another episode. I'm like, there's literally no time to do it. Although Ron behind my back blames me to everyone.
All right. I mean, I do say it's a scheduling conflict for Clint.
But somebody has worked like 22 out of the last 23 days or something like that. And
I tell you what, boy,
not me.
That paycheck hit today, and they are not taking enough taxes out. Let me tell you.
Oh yeah.
Yeah.
Ugh.
So I was going to open with, actually, you know what? I want to open because Kyle gave me a bunch of gifts yesterday.
A bunch of gifts?
Yeah, he gave me 3 gifts, and they're awesome. And that was part of why I didn't start working on Kyle's episode right away because I didn't want you to see it because I know it's on there.
I don't like this live reveal.
I think you're really going to enjoy this.
I feel pressured.
This would be a great
Is this going to go on the merch store?
it should. Ooh, I dropped my
Oh,
towel.
I like it
There
already.
you go.
No way.
Yeah, dude.
Oh my gosh, dude, that's awesome. Oh, this is gonna be my regular sipper now.
Yeah.
So if anybody can't see it, it's like a rocks glass.
Yeah.
But it says the mighty levitoracipam.
Yeah. Mine,
Oh, that's so good.
mine's got like my name, and he was making fun of like all the, letters and stuff. And it was like NP plus, etc.
Oh yeah, like all your
Yeah, all the little letters and stuff. That's why it was funny, when I first started working and Sue was ordering my coat,
yeah.
and she's like, well, what do you want it to say? And I was like, NP. And she's like, none of this other stuff. I was like, nobody cares or knows what those things mean.
You do have all that on your
Email signature?
Email signature.
Well, how are they going to know if you don't tell them?
Well, I've been needing to change mine with some of my
Yeah.
credentials, but you have to submit like a formal request for that, don't you?
It's not hard. It's on the internet, and you literally just type in what you want, and it sends it over.
Okay, I need to do that.
Yeah.
You don't want to have too much, but at the same time, if you worked hard for those credentials,
Yeah.
you want them displayed somewhere.
Well, and it's the whole thing, like in forward facing, right, patient care and whatever, like nobody knows, even for you, like nobody knows what CAQ or any of that stuff means.
Yeah.
I know what it means. In the formal setting, like, whether it's in business or academics, then it becomes somewhat relevant. So, but which is why I have it. But
You want that on a CV or a job resume.
Yeah.
You want that in any type of like you said, formal presentation, academic situation, but otherwise it doesn't matter. The education matters.
Yeah.
It makes you what I think a better, well-rounded provider, but it doesn't matter.
yeah, there was like, I don't, I'm not even going to repeat the joke. It's some joke about how NPs have all the letters.
I've
And I'm like, dude, nobody, it's not our choice. I didn't make them make it an AC and PC, AG.
-C is so much easier.
Yeah,
I'm gonna give all
NP-C.
my PAs out there the love, and instead of the AGNACP, FNP, BC, DC, FN.
Well, and it's funny because like NP, so like when you finish your nursing degree, right? You go take a test, you get a license, and then you're a registered nurse.
Right.
When you finish NP school, you go take a certification, and that's what those letters are.
Right.
And then you apply for a license, and then you get that. So it's, kind of
it's same way for PA. Like you pass the certification exam, which you have to be a practicing provider. But same as you said, like you can be, which is the importance of the C, right? So you can be a PA, which means you completed a PA program,
right,
and you have the diploma, but it doesn't mean that you passed their certification exam, which means you didn't pass boards. So you should not be a practicing PA. I'm assuming it could be the same for an MP. You're an MP, you completed an MP program, you have the diploma, but you didn't pass the cert.
Well, if I'm not mistaken, the same thing can apply to physicians.
It can.
You can be an MD, but then if you drop out of like your fellowship and you don't want to do anything, like yes, you're a medical doctor.
Okay, you want to hear how just convoluted the vernacular gets here? So if you look at that, I am a physician assistant now. And only because I'm talking about semantics,
physician associate.
It's now physician associate.
Right.
I don't care if you call me a physician assistant, but we are physician associates. A physician who completed medical school but never completed a residency can still work under a supervising physician, I believe, as a associate physician.
Oh, interesting.
If I'm phrasing this correctly. So instead of a physician associate, it's an associate physician. So it means, again, same as we're talking about, you've completed the didactic portion, but you haven't completed the training or passed your boards for internal medicine or whatever the case may be. So you're a doctor, but you can't legally practice under that.
Yeah. You're a doctor, but you're a doctor.
Kind of, sort of.
Yeah. It's like, what's the difference between an attorney and a lawyer? Like a lawyer, I think I could get this wrong, but one of them is I've completed law school, but I've not passed the bar. One of them is I've passed the bar.
Same type of premise.
Yeah.
And we digress.
Yeah. So welcome back. Right. I was actually going to pull up cause it just hit this morning. So I thought it'd be kind of fun. Do you get the real world boards questions from,
who are you getting them from?
Palm CCM.
Yes, I need to update. Like I haven't been getting my Palm CCM updates. Is it now a paid subscription, or did we just funnel it to all go to the?
I mean, I get them on both. So
I'm not getting them on my personal anymore.
Yeah.
But anyways,
shout out to Palm CCM. As far as I'm aware, this is a public thing, because I know when you go to it, there's more to it that you have to pay for. But this is just in the public email. But they do these real world board questions, and they come out like, I don't know, once a week maybe. So today is real world question number 21. A 48-year-old man with ESRD and a new pleural effusion. They've been getting progressively harder, and a lot of them honestly are designed to be like, a lot of them are designed to be like the right answers. It could go either way.
Right.
So
pick the most right answer.
Yeah, shout out to Palm CCM. Sign up. Their subscription, I want to say, is like $6 or $7 a month. It's totally worth it.
There's lots of other resources that we utilize, but Palm CCM, for anyone out there, is a great resource. And we're not sponsored by them. No. We're just giving a shout out as far as...
Unless you want to.
Updates in critical care. And it gives you a nice little synopsized kind of tidbit on what their takeaway is. And then obviously you can go to the... individual studies yourself and things like that, but it's a good little resource just to kind of see what's coming out.
Yeah. Also, any mid-levels, physicians, open evidence, I've been using that a lot more, has been a really great resource. It's a chat GPT, but for medical journals, which I know for us with medical licenses, you have an NPI and you can sign up and you get it for free. I believe that you can pay to use it as well if you don't have an NPI.
Okay.
So, but I don't quote me.
I've just been dabbling. I haven't been using it as much. But yeah,
I really like it. It's obviously not as friendly as ChatGPT is, but it's very direct, which is what I like. Yeah. And you can ask it nuanced questions, and it'll be like, there's no literature that really supports that. Now, I will even say this though, because I'm still very, very big fan of ChatGPT. If there's nothing in that medical literature, but you're trying to think about a problem, you can ask that, but ChatGPT is also very good at reasoning, you know?
And what I'll often do in my prompt for ChatGPT is I'll ask it to pull from cited sources, journals, or societies. And I'll say, you see my prompts all the time, like per chest or per
IDSA.
SCCM or IDSA or whatever the case may be.
All right. So, and I'm going to give the disclaimer because it's in the email, but these are real world boards, as in the real world, there may be no single right answer and you're only competing against yourself. Okay. So don't get in your head if you don't get this wrong to anyone or don't get it right. If this is someone who's listening to this. So we got a 48-year-old man with end-stage renal disease on chronic hemodialysis who underwent successful routine permacath tunnel dialysis access placement 2 days ago. You were called to his bedside for respiratory distress. He is in mild distress with tachypnea and a new 3 liter per minute oxygen requirement. He describes right-sided chest pain, blood pressure is 126/70, that's down from 166/90, heart rate of 111, respirations 22, SpO2 is 96%, and he's afebrile. Hemoglobin was 9 and is now 6. A transfusion of 2 units of packed red cells has been ordered stat. A chest film after the procedure 2 days ago was unremarkable. A new chest radiograph is obtained. Oh, you can't see it. Let me forward you this email real fast.
Just flip it around and show me. I won't look at the answers. Okay, got it. Yep, good enough.
Okay.
I don't want to look too closely.
I feel like we already kind of know what direction this is going in.
Sounds like a hemothorax.
Yeah. So, and then a bedside thoracic ultrasound is also obtained, which shows this.
Okay.
I think we already have a suspicion of what's going on here.
It's not as big. From what I can tell, though, they had some Doppler flow on there. That's to show the pulmonary vasculature. So it looked like there was some consolidated lung and it wasn't all fluid. Yeah. So there was a little bit of pleural effusion, some consolidated atelectatic lung tissue.
Yes, I agree. I agree with your interpretation. Poll. Based on the information available, what is the next best step? Place a large bore chest tube. Place a smaller bore pigtail tube. Thoracentesis, chest CT, or urgent hemodialysis. In twisting.
What was placed, the cath, what kind of cath was it, did you say?
A tunneled permacath.
Tunneled permacath, so up. So it's a subclavian or something like that, so a tunneled permacath.
And by the way, when I put this up, I will take this. I'll take the picture and put it up so you can see what we're looking at.
I think I could make an argument one of two ways. Yes. Right. I could go with thoracentesis, or I could go straight for the pigtail chest tube.
Right.
Based off of the ultrasonographic findings, I didn't get a great look, and they may not be trying to get at this, but there are certain things that you can see on thoracic ultrasound that may suggest more of a hemothorax than just a simple pleural effusion, which we would suspect to be more related to the ESRD, right?
Your messaging is active on your laptop, right?
Yeah.
Okay. I just sent you the image. I need text.
Should be, unless my attached to my. Oh, okay, I got it. All right, it's more obscure than what I was thinking. So now I'm not overly convinced that that's lung, and that might not be like heterogeneity of like some coagulated blood, except for the Doppler flow showing the vasculature makes me think that it's pulmonary tissue.
Yeah.
What I was going to say is, you can look for either, sometimes I have said it before, it's going to be hard to see without images, but you guys can go look it up, a plankton sign, which just shows like exudate floating, proteinaceous exudate floating around in the pleural fluid. It's more suggestive of obviously an exudative effusion. And then there's something called the hematocrit sign, which is where you'll get separation of the blood to the plasma and the RBC constituents, and the RBCs, platelets, everything will settle.
Like the hemosiderin.
So the bottom will look a little bit more hazy or hyperechoic. The top will look just more hypoechoic or just like regular simple fluid. I don't really see that here. There's like a little bit of fluid pocket that I'm wondering if it's like either fibrin from clot or loculation. So I think given the context in this one, I'd probably just go for a pigtail.
Just go straight in for a pigtail?
Yeah, because I would say do a diagnostic thoracentesis to see if it's blood, right? There should be RBCs over a certain amount, which I should know off the top of my head, but I don't. Maybe over 2,000 that would suggest a hemothorax. Maybe it's higher than that. But given the context of hemothorax, looks a little complicated. Looks like there's maybe some fibrin and stuff in there. The literature, at least now, supports a smaller bore pigtail catheter for hemothorax, even empyema, complicated effusions. Like it's not the traditional dogma previously where you have to go straight for a large bore chest tube, thinking that you're going to need a larger bore lumen to drain this like coagulated or pustulant material and stuff. You know, a pigtail's fine. So I think given the clinical context, I would say just go straight for a pigtail, but I also don't think that a diagnostic thoracentesis, then pending results of the diagnostic thoracentesis proceeding to a pigtail would be wrong either.
Yeah, which is why there's no right answer. The answer to your question is when your pleural fluid hematocrit is greater than 50% of the patient's serum hematocrit.
Okay.
But arbitrary markers greater than 100,000 is concerning for significant blood. Greater than 500,000 often correlates with pleural fluid hematocrit around 50%, and greater than 1 million strongly suggest hemothorax.
Okay.
So, yeah, I mean, when I read this, right, like there's an obvious blood loss problem,
right?
You know, we're just making the assumption that it's in the chest. We obviously have some new hypoxemia, so we're requiring supplemental oxygen. We've had a statistically significant drop in your blood pressure, got tachycardia, and, you know, I think they made the mention, and I'm just working through the stem, right? I think they've made mention of, you know, being afebrile because so many people jump right to sepsis, right? 2 days ago, you know, cath, blah, blah, blah. So, you know, hemoglobin's 9, it's now 6, transfusion of 2 PRBCs, and kind of the sum total of evidence. I think that it's a pretty safe bet, right? Now, the etiology of what you're dealing with is a different story, right? Is this like some sort of like intercostal, you know, slow leak from the actual insertion, which is, I think, the most likely scenario in this case. And I know they mentioned, you know, quote, new pleural effusion in ESRD, which can, you know,
be a lot of different things there.
Yeah,
or just be related to, you know, transudative pressures, fluid overload.
Yeah. So I'm with you because I think, and at least in our practice, I think these days we're more prone to going straight into pigtails. You know, let's save ourselves the trouble.
Yeah.
So we're gonna go with pig.
I'm gonna go with I'm gonna go with pigtail.
Okay. Let's see. And I'm not gonna go through the whole breakdown because I don't want to break the paywall. Like, you know,
I just want to know if I'm right.
So and this is all public poll. It doesn't tell you. Well, it does tell you which one's considered correct. The majority of people said place a large bore chest tube. That's 43%. The correct answer. I don't
agree with that.
No, the correct answer marked on here is place a small bore pigtail tube, and that was 23%. 11% said thoracentesis. 19% said chest CT, which I don't disagree with the chest CT necessarily, but we can get a pigtail in pretty fast. You know what I mean?
And you know, just to be our advocates for ultrasound that we always are, a bedside thoracic ultrasound exam is more sensitive for looking at like a loculated pleural effusion, septations, empyema, things like that, than even a CT scan is. If anyone hasn't looked at a CT scan of the chest and tried to see loculations and pockets, and you're almost looking for a difference in the pleural line and how fluid should layer. Admittedly, right, I am not an expert at looking at CT scans of the chest. In PA school, we get radiographic training, but obviously things are much more targeted at baseline chest x-ray, some CT scanning, but not to the point of a pulmonologist or a critical care physician, right? Let's just make a blanket statement there. However, in the years of my practice, I've tried to, you know, work diligently to become better at these, but it can be hard to try and elucidate those changes in, what am I trying to say here? Density of fluid on a CT scan.
Yeah.
Is this a loculation? Is it not? It can be. So ultrasound is actually more specific for those things. So I don't think that getting a CT scan right there on 3 liters, they're hemodynamically stable. Although I wanted to make that point, they are hemodynamically stable. But remember that a significant change in your blood pressure from baseline, and I'm pretty sure it's a drop in greater than 40 millimeters of mercury in your systolic blood pressure from your baseline, is still considered hemodynamic instability. So though this patient, just a good little teaching point, though this patient's blood pressure looks stable on the monitor at 128 or something like that, that is a significant change from their baseline. So in the lieu of the 3-point drop in hemoglobin and what we could classify as unstable hemodynamics from their baseline, I mean, this patient would be theoretically in I don't know if we're going to call it hemodynamic shock. I don't know if he has any, he's having organ dysfunction, right? He's having worsening hypoxemia,
right,
potential other issues. So you could certainly make this is obviously acute blood loss anemia, and you can make the argument that this is hemodynamic shock or hemorrhagic shock. Sorry.
Right. Yeah, they said ultrasound shows a collapsed right lower lobe with hyperechoic material in the right hemithorax. I'm not going to read the whole thing. I'm trying to just kind of peruse through it. I'm trying to see if iatrogenic hemothorax is a likely diagnosis, which we figured, right? Thoracentesis is advisable for most pleural effusions of unknown etiology. In this case, aspiration of frank blood would support the presumptive diagnosis, but it might also impose an unhelpful delay or confusion.
Right. And that was kind of our whole reasoning, right? You're pretty positive you know what this is. The treatment for hemothorax is a pigtail catheter. So,
so let me jump on that because there's a part. So it says virtually all studies and guidelines have centered on traumatic hemothorax. The management of iatrogenic hemothorax is extrapolated from them. Large bore thoracostomy, so 28 to 32 French, has traditionally been advised for drainage of hemothoraces on the presumption that these catheters will be less likely to become occluded by a clot. However, numerous small studies have found that smaller bore chest tubes, 14 to 22 French, can successfully drain hemothoraces without occlusion or other complications. Bingo.
It's like we kind of know what we're talking about.
A little bit. We're kind of there. Have we made it?
No. I'm always working to make it, always striving.
Kyle and I talked about that on the last podcast, how it's like, there's never like, oh, I've learned everything. No. Like I'm good. We've
talked about it before, and I can maybe just give the listeners and learners out there just a little bit of encouragement, because even for us doing these podcasts and stuff, and I've probably mentioned this before, but me and you have talked about it a lot, just personally and off air, I guess you could say. But, I tend to go in waves. They're all, when you're a working professional and you're not under strict
there's no academic gun to
timelines and things like that to perform for an exam and stuff. It's like, if there's a period of my life where things are a little bit slower and I'm motivated, then I, make hard pushes to continue to improve myself. And then honestly, there's times in our lives where you're working a lot, life is busy, and you just lose some motivation. And I've just had to come to the conclusion with myself, because I'm a very internally driven person. And then I tend to feel like if I'm not moving forward, you're moving backwards, right? Which unfortunately is true in medicine, because if you're not staying on top of it, then you're not staying stagnant, you're moving backwards.
I'm trying to remember how the adage goes. Like, there's some cases where you have to run just to stay in the same spot. Yeah. And I wouldn't say it's a run, but you have to stay moving.
But what it does is it helps motivate me for when I become motivated again. Because when I get demotivated and I'm not looking into things, inevitably something will happen, and it will make me feel very inadequate in my knowledge and preparation. And then I get anxious about my lack of knowledge, and then I'm now motivated to okay, I got to keep getting after it.
Well, and there's so many things that we do that, and I'm not saying this as a fluff, but there's certain concepts in medicine that are inherently complicated. Like you and I had a long hemolysis discussion the other day, and I'm not going to say hemolysis is necessarily complicated on its face, right? But when you're trying to suss out, is this HUS, is this AMAHA, is this TTP, is this ITP, Like, and we're not hematologists.
No.
This isn't the hematology ICU, but inevitably these patients are going to show up and you're going to be like, well,
just, I mean, we could do a whole episode on that, but trying to determine the etiology of thrombocytopenia in the ICU is so convoluted anyways, because there's so many reasons that a critically ill patient in your ICU can have thrombocytopenia. It depends on the degree of thrombocytopenia. Do they have any associated anemia? Are they having vascular phenomenon or consequences, thrombosis? Are they having, it's like, it's not just their platelets are low. Right. Like pretty much everyone's platelets are going to be low. It's in the context of everything else. So it's never easy.
Well, I was, who was I talking to the other day? We were talking about anemias and breaking this down because it was that case that you and I had talked about. And I was just like, this is case. Yeah. And I was like, this is one of those cases where all those little metrics on your CBC that you never look at
matter.
This is where you got to look at them. Yep. This is where you're trying to interpret what's going on. But completely unrelated to this, we just got a new subscriber on YouTube. Shout out to Emma Gonzalez. I don't know.
Hey,
I don't know. I just got the email.
That was a good practice question. I like that. Gave us some opportunities to talk about. I was
going to ask you if you wanted to do one more.
Oh yeah, sure.
Because they pop up on here all the time. Let's see.
I don't know. I kind of want to stop while I'm ahead.
I've never, and this is not a slight against anybody. I've never run into one that was that difficult. Like, because
it says that before I miss the next one.
Well, I think they're totally correct in that, like, I think you could do either one and you'd be fine.
You could have done the Thora first and no one would have come to you in the hospital and said, no, that was the wrong way to do this. Yeah. You could have gotten the CT scan first and no one would have come and said, that was the wrong way to do this.
You're an idiot. Yeah. You know what I mean? No. You know what would happen? Dr. Patel would come up and go, no, bro. This is obviously,
Come on, bro.
I love that. Someone did that the other day and I was like, that was a perfect Patel.
Yeah.
That was so good. All right. So we'll do one more. This was from from a guest. So we have a 52-year-old female who was admitted to the med-surg floor for high-risk NSTEMI. In the emergency room, she has non-specific ST wave changes on her ECG and an elevated high-sensitivity troponin. She's pending a cardiac catheterization tomorrow morning with interventional radiology, but goes into a wide complex tachycardia on the floor. The nursing team calls a code blue, and you respond to find a conscious, uncomfortable-appearing woman who is not in severe distress. The admitting team hands you the following ECG and asks for your assistance in managing the patient. Let me send it to you real quick.
Wide complex tachycardia. Okay, so I'm thinking AFib with aberrancy, right? Mm-hmm. Or some type of ventricular arrhythmia, but if she's not in distress... Oh, bro, that doesn't look like a wide complex tachycardia.
Well, let me read the rest of it. So you take a look at the ECG and read it as rate 150 to 160, rhythm, not sinus rhythm, no obvious P waves, not coming from the sinoatrial node. Axis, a little tricky, with AVR being negative and 2-3 and AVF being positive. The axis is likely between normal and rightward deviated. As we'll see, this is a bit atypical for this condition. Intervals, wide complex QRS, no PR intervals. Morphology, the 10th and 13th beat look different. That's the blue box that's highlighted. They're not truly sinus beats, but not quite ventricular either. You discuss the patient with the admitting medicine team, and they are very concerned. She's currently hemodynamically stable with a blood pressure of 130/85, respiratory rate of 16, oxygen saturation of 99%, on-room air, and afebrile. The medicine team asks for your opinion on what to do next. God, I picked the worst one. This is question 20. So it says, what drug or procedure do you recommend? Amiodarone, lidocaine, procainamide, beta blockade, i.e. esmolol, or DC cardioversion.
All right. I don't think it's esmolol because we don't have an echo to discuss any type of EF, right?
No.
So, and that's more so for the non-dihydropyridines, but that's kind of my thought there. It's a wide complex QRS, right? So I'm thinking either amio or lidocaine. We're not sure if this is strictly a ventricular arrhythmia. We don't have P waves and the rhythms are regular, correct? So this could be AFib with aberrancy. This could be probably lots of other things. I should be able to name more things, but that's what comes to my mind for an irregular Y complex tachycardia. So I'm probably going to go amiodarone. You said DCC cardioversion.
Yeah, that's an option.
But she's not in distress.
No.
Right? She's hemodynamically stable.
Correct.
And she's not having ongoing chest pain.
No, doesn't say anything about chest pain.
So it was amio, lidocaine, esmolol, or cardioversion?
Yeah, it was amiodarone, lidocaine, procainamide, beta blocker, or cardioversion.
Oh, procainamide. Let me see here. How old is this lady?
50, in her 50s.
I'm looking for any of those. What's it called? Is it a J wave?
Sorry,
what's the little blip you get in Wolff Parkinson White at the beginning of the QRS complex? But that would still be narrow complex unless it was antidromic.
So I'm actually reading through it while you're doing this. They're basically saying it's VTAC. They're saying it's inconclusive, but it's some of the evidence is leaning towards VTAC over SVT with aberrancy.
Okay.
Now that being said, the discussion on this one is so deep I can't really break it down here. But
I wouldn't think this, other than looking at V2, V3, I wouldn't think this is VTAC. Just looking at it, would you?
Say that again.
Other than lead V2, V3, I wouldn't look at this and think that it was VTAC.
I would be slow, but like you're saying, 2-3 look ventricular.
Yeah.
And then I think, having the beat discrepancy on the bottom. Do you see the blue box?
Yeah.
So basically, I went with lidocaine.
Okay.
And I'm not going to lie to you, I went with lidocaine because I knew this was a tricky question, and that's a drug we don't use a lot.
Yeah.
So I went in that direction. Because, think about it. How often do we go to lidocaine for some sort of cardiogenic issue? EP is usually involved. And
the whole reason that I picked amio versus lidocaine is because of their irregular rhythm and me thinking it could be AFib with aberrancy. Otherwise, VTAC, I would have gone for lidocaine. But.
Yeah. So the majority of people picked amiodarone, which I don't think would be a bad one. In this breakdown, they go down to the studies, but it's really focusing on lidocaine versus procainamide, and it looks like the quote-unquote correct choice is lidocaine. But they're showing that basically it says that there's not a lot of good options in this setting, So this is definitely one that I think is worth a read.
I'll have to check it out.
It's in the email.
If there's a chink in some of my armor, I'm not an electrophysiologist by any means.
No.
So,
yeah. So, anyways, we'll kill that.
All right.
Because I think you wanted to get into a little bit of some of the stuff we talked in at the vent conference.
Yeah, I thought we would just maybe we can give like a low level. We've been chit chatting for a while already, but just kind of low level run through. Just kind of hit the big topic points for that's why we covered some other things for those of you who attended the conference. Thank you for attending. Yeah. It was our first time doing an in-person or a live presentation together as both of us as clinicians and educators, but also as the Full Code podcast. So that was interesting and very cool.
We didn't know how that was going to go.
Hope to do more of that in the future.
Yeah.
But if you didn't, then we can kind of cover some of the stuff. The topic or the name of the presentation was Do No Harm, but it was Do KNOW. So like you got to know, do no harm.
Clever.
See that? See what we did there? And it was just kind of outlining the often oversighted but real risks that are involved in what seem like everyday mundane tasks and procedures that occur in the ICU, just to illustrate that, though this is routine and it's something we do on a regular basis, that shocker, we are taking care of critically ill patients, and every decision that we make does have potential ramifications, and some of those quite severe. And so just to take that cognitive pause, we'll throw that term out there. That's been coined by plenty of other people. We're not going to take any ownership over that. Critical Care Now, some other podcasts talking about a cognitive pause, but and really think about, is what I'm about to...
It was the diagnostic pause.
Diagnostic pause, cognitive pause, diagnostic pause. Is what I'm about to do going to change the care for the patient? Is this going to benefit us or the patient? Or how long is this intervention going to be necessary? And is it something that I can potentially not do and not put the patient at this risk?
Well, so I was going to jump to, we had briefly spoken about this, but I felt very, I feel very conflicted because, Everdac just came out, right? And I think arterial lines are fine, right? Because this was part of our presentation, arterial lines. Now we talked in there about how the utility is sometimes questionable, right? Yeah. Because if you can get good reliable cuff pressures, and you have a patient who's, let's say, not having escalating vasopressor doses or extremely high doses or whatever, and you can survive on a cuff just fine. Now Everdac just came out in October, basically saying that. And again, we've referenced this before. What is the end point question that we ask? Does this influence mortality at all? And it turns out, having an arterial line and using that to manage vasopressors or something going on with your blood pressure doesn't impact your mortality at all.
And I've said this over and over again when we've talked about SWANs and CVPs and other things. I'm a data points guy. I don't want to rely on any one data point, but the more data that I can gather that's going to help me make my clinical decision moving forward, I like having. But at the same time, we've talked a lot about other things that we can do at the bedside point of care ultrasound assessment, the good old capillary refill and danger shock and Andromeda shock, and ways that we can assess our patient's perfusion status without just getting real-time numbers. And you can probably honestly make good hemodynamic assessments and adjustments just based off of those things. Now, if we've both talked about it, if we have time and this patient does have escalating vasopressor requirements, especially if this is a little bit of an undifferentiated shock or it's truly septic shock with escalating vasopressor requirements, I suspect that this patient is going to be on vasopressors for at least a couple of days, maybe 48 hours, right? And getting a arterial line would still likely behoove us and potentially be beneficial, especially even just for the case of frequent arterial blood gas monitoring, those types of things. However, say patient, it kind of depends on the patient, right? If they come up and they look like they're clinically improving quickly, maybe they have some more signs of some hypovolemia and you're resuscitating them, their blood pressure is improving, then I'm definitely not going to be jumping straight to putting one in. We actually just shared a patient recently. I don't want to say anything too close, but if I say what they have, it's standard ICU admission. So this isn't going to relate to any one specific patient, but DKA patient, obviously very hypovolemic, as happens in the DKA. Check. In the DKA physiology, had escalating vasopressor requirements. Yeah. They wanted an arterial line, but I was fairly positive that this patient had been, under resuscitated at this point, that they were still quite hypovolemic, that they needed continued fluid resuscitation, and that we would see improvement in their hemodynamics without it. We were getting good cuff pressures. I did not put in an arterial line, and within, less than a day, we had significant improvement in vasopressor requirements. So I'm not getting into any of that. I'm just using it as an example as far as the arterial.
Well, you know what was funny about that scenario? So that, they handed you, you weren't there when I came because I was working nights. So, but I was already aware of what was going on, and I texted you and I was giving you a hard time about some of the stuff.
That I didn't order a serum osm, which I could have sworn that I checked the box in the order set. But.
Yeah. Well, I saw it and I immediately was like, which one of them did this? Because it couldn't have been Clint. It could not have been.
He texts me, he goes, you had a DKA patient with a glucose of
1100 or whatever it was.
In the thousands, and you didn't check a serum osm. Who are you? I don't even know you.
So
it was at the end of my shift.
I'm trying to think if it was the second or the third night. So, because you had texted me, this patient also had a rapidly rising troponin, but didn't have any, was essentially asymptomatic, no chest pain. EKG was benign. So, cardiology is GDMT. Yeah. Good luck to you. Anyway, I think it was that last night that I was on, there was like, we had like 2 near codes and then another person code, and it turned it out to be that person who had a brief asystolic arrest, which who knows, may have been just a prolonged systolic pause. But it was funny because I had seen this person for days at this point, nights, but multiple nights in a row, and like didn't look like a very healthy person, like didn't breathe in a way that you would think a healthy person would breathe, kind of thing. And anyway, right after the arrest, like would still wake up and talk, but like was breathing in a funny way. And to me, she had been breathing the same way the entire time. And one of our attendings was like, let's just intubate her. She's not breathing good. She's using accessory muscles. I'm like, I mean, she's belly breathing, but there's no there's no like tugging. There's no intercostal retraction. There's no hypoxemia. Gas is benign. Like it's more of an obstructive, I think, than anything, And people were like, oh, see, I told you. And I was like, take it up with Dr. Coulter. He's been seeing this patient for 2 days. And it looked totally fine. But my point was, as soon as we got the tube in, somebody turns around and goes, all right, do you want to put an art line in now? And I was like, still no.
Answer still no.
Still a big negative, dog. I'm leaving. Yeah. I'm going home at 6 a.m.
Well, and I made a conscious decision to not place one because I did end up placing a central line on that patient, right? Because they needed one. We didn't have access and things and had dual vasopressors, but I made a conscious decision to not put one in that patient because I was going to, and then we were like, one, hard stick, difficult kind of situation, but I was fairly confident that we were going to do okay with that one.
Yeah. Well, and in your defense, that patient had a rapid de-escalation of vasopressor requirements once adequate resuscitation had been done.
Right. Exactly.
So I think that patient did become cardiogenic. I think the next day their LVF was depressed, all that stuff. But I'll make this one last point on there. Part of the EVERDAC is that the complication rate favors a non-invasive approach. And it's not necessarily that and we've mentioned this if you went to the vent conference, we mentioned this, but it's not like the complication stats are very high. But as we mentioned, I think when we were talking about intubation, even a complication risk of 1% is significant, right? So, and they cite in here that your hemorrhage occurrence is only approximately 1%, which is still not nothing, right? Now, granted, how often do we worry about hemorrhage from arterial line, especially in somebody who's not performing like a PCI and doing aggressive manipulation? Right. Not that big of a deal. However, that being said, once you transition, maybe I've said this incorrectly, to be clear, in the invasive group, because it's an invasive group and a non-invasive group, in your invasive group, so the ones that, in this selected population, they had a hematoma rate of 8%, which is definitely not nothing, right? Yeah. Now,
hematoma, pseudoaneurysm, risk of distal malperfusion,
nerve damage.
You do have an ulnar artery. That's why everyone performs an Allen's test, all that kind of stuff. So
isn't the Allen's test like been bunked out at this point?
Oh, that's a good question. I don't know. This is from back in my RT days, but anytime I would go get a blood gas as a respiratory therapist, you always had to put in there if they had a positive Allen's test or not.
Yeah.
Been debunked, or just saying you don't have to do one?
Well, hold on, let me Google. I'm not Googling it, but I'm using open evidence, everybody. So I'm going to put it just like I said. Has the Allen's test been debunked?
I can't get over it.
Do you love it?
I love it,
dude,
so much.
I love that thing.
It's one of those, we've talked about this. It's one of those mistakes that in a public face and being on a podcast, I'm like embarrassed and ashamed of it. But also I think it's just it's funny. Yeah. People will never let me live it down.
No,
but I don't. We're all not perfect.
Yeah.
So.
Well, it was funny in the moment, but I think to us, we kind of just let it go, but it comes up all the time.
It's been a thing now.
Yeah. And now you have
it's got to be a shirt now.
Dude, I know. Well, Brian sent me, oh my gosh, I'm going to have to put this up on like the video when this comes out. But I think Brian saw the clip I posted yesterday, and he made this little blue frog that says, "I'm afraid I just
you're gonna have to share that
myself."
Yeah,
It's gonna have to go on. I said, Brian, I said, dude, you're gonna have to start making t-shirts for us. That was good. Awesome. That was good stuff. But on the note of the Allen's test, so it says this is what open evidence says. The Allen's test has not been definitively debunked, but current evidence strongly indicates it's unreliable for predicting hand ischemia and should not be used as a triage tool to exclude patients from radial artery access.
Okay.
Booyaka!
No problemo if you don't do an Allen's.
That being said, this is not medical advice. Please follow your institution's protocols.
Yes. Very good disclaimer.
Yeah. Which when these come out, I always usually put it in the beginning, but
we'll hit it.
Yeah. So anything else on arterial lens? That one came to my mind first because
I guess the only other thing that I would say is, and I don't, not that our bedside staff wouldn't know this, but me and you have talked about it. The other argument that you could make is like you can use arterial lines, which you outlined in your lecture. You can use arterial line pulse waveform analysis to kind of clue you in on potential etiologies that's going on with the patient, and specifically for like fluid responsiveness and other things. However, as I went down these deep rabbit holes, right, the what am I trying? Not selection. The pre-met criteria that have to be made for you to actually be able to make a clinically accurate interpretation of fluid responsiveness based off an arterial line are pretty kind of rigorous things to make, right? Like normally we're always recommending, if they're on mechanical ventilation, that we're targeting like 6 mLs per kilogram of ideal body weight, like, lung protective strategies, that kind of stuff. Well, they have to be 8 to 10, or at least over 8. I think it's 8 to 10 mLs per kilogram of ideal body weight. They have to be in normal sinus rhythm. There's lots of pre-met criteria that have to be in place for you to even say, based off of pulse waveform analysis, if someone could be deemed fluid responsive or not. And so it's really not as easy or straightforward as you can't just look at the A line and be like, oh yeah, this patient would be fluid responsive. There's a lot of things that have to be in place to make that determination. So that's not a huge reason that I'm going to place one. Again, I always go back to ultrasound, but the different pulse waveform analyses that you can see that would clue you into, potential etiologies. A lot of that stuff you're going to see on thoracic ultrasound if you look yourself, as far as pleural effusions or tamponade physiology or those types of things. So it's not like by placing one, you're going to gain a whole lot of benefit in any of those areas either.
Well, and I think, we talked about this in the arterial line class if you went to that, and we will offer it again. There will be more of these, but there's even a lot of misnomers, like when we talk about pulsus paradoxus and pulsus alternans. I think historically people, and I know I've heard this many times, like when you see somebody who's got pulsus paradoxus, some people will say, oh, well, that means they need fluid. And it's like, not necessarily. It depends on what's going on. And really, the etiology of paradoxus is not really indicative of fluid need at all.
No.
Now, could it be exacerbated by it? Sure, you can. But you cannot use any, and we've talked about this a lot in hemodynamics, you cannot use any one data point to make a decision. Now, which we talked about a little bit in the discussion with Heather, you can use like your NICOM and stuff to calculate like cardiac power, and you can do stuff with that. If you have a patient who's got an Impella, you can look at your PAPI, right? There are a lot of other little things, stroke volume variation, pulse pressure variation. There's things in there that you can use, but just like you said, it's not like A plus B equals C equation. Like you have to take the sum total of the evidence, and then even then you're making your best educated guess, right? But you're obviously trying to make that guess as educated as humanly possible. But I think the first thing we had talked about in the presentation was intubation, and I don't know if I told you about this because I did a bunch of nights, bunch of nights, and one of the nights it was like, and I'm not saying this to give anybody a hard time, just so you guys know, but I swear to God, the nurses can smell like when I've gotten comfortable somewhere. I had eaten.
He just rested his head.
Here, text him. And it's usually 2 at the same time from different places.
You literally have just gone.
Well, in this case, this was really early into the shift. So, which is good because I always appreciate proactivity. But like we had pretty uneventful nights for the most part. Like I got racked with UMA one night. But other than that, we had pretty uneventful nights. I just ate my food. My tum-tum's full. I'm
feeling
like,
nice and comfy.
I'm sitting in front of my heater, and then all of a sudden, ding! First text was, "Hey, this patient in this room, we're pretty certain that their ET tube cuff is blown." And I'm like, stellar, right? So I like pull the chart up real quick just to take a gander, and then like almost back to back, my phone, bing, and it was a patient I had gotten warned about early on. It was like an afternoon extubation that was kind of stridorous, had some racemic, and they're like, "Hey, she's not looking so good." And I'll appreciate this too. The person who texted me was like, "Hey, you don't have to run down here right now, but this person doesn't look good, and if they get worse, I'll let you know.
Right.
But like, if you could, like, if you're heading this direction." And I was like, which I really appreciate, right? Give me a metric for what's going on. Anyway, I go over to, because one's in neurotrauma, one's in MI.
Okay.
So I'm like, all right, I'm going to go to MI first. Plus, I mean, blown cuff could be, in my opinion, could be worse.
Right.
So I get there, and I don't remember if it was one of yours or I don't think it was from through the day. But as soon as I get there, they're like, he's like 98% leak, but satting 100%, pulling volumes of like 1400. I was like, when I woke him up, like sits right up, sticks the tongue out, and they're planning on extubating him in the morning. And I was like,
pull that puppy.
Yeah. I was like, just take it out.
Yeah.
And it was really funny because and you know this, right? Like, especially as a mid-level, sometimes you get really hesitant about making decisions.
Yeah.
Just because you're like, this is what I would do, but my attending might not do this, right? And I don't, and they're obviously, they're pulmonologists. They have more experience in this area. They have more training in this area. And we learn from them, and we learn through our practice as well. But sometimes there's like one little thing that they'll see and they'll be like, oh, I wouldn't have done that. You know what I mean?
Well, and to that point, and this is just differences in how we practice, right? But if anyone out there hears this is for everyone. I am more than happy to help the group. I work for the pulmonary critical care group, but I work with a singular physician. I'm one-on-one.
Yeah.
And so that, to your point, that's one thing that I see as a huge benefit. Now, obviously every service throughout the United States, a doc and an APP can't work one-on-one together. I understand that's not feasible, but all of our docs love you. They know that you're clinically solid, sound. I think they would all trust your decisions, but there is something to be said about when you work with the same doc over and over and over again, that level of confidence and trust that you can gain.
Yes.
I feel much more comfortable making my own decisions and just giving orders for those types of things. Or if someone looks bad and they need intubated, just intubating them without even, if he's in a bronchoscopy or something like that. It's like, okay, the patient obviously needs intubated. I'll intubate the patient. I'll tell him when he gets up. And if I have the opportunity, don't get me wrong, I'm still going to always update your physician first, as you should as an APP, right? But I never feel any like he's going to be like, oh, that was the wrong decision.
You're an idiot.
I wouldn't have done that.
Right. Right.
So you're definitely in a little bit more of a strenuous situation in the sense that you're switching attendings on a daily, if not regular basis, and everyone has a little bit difference in practice pattern. And so that makes things
and some of them are
different.
kind of big differences. Like we were joking the other day about when I had transfused a coagulopathic cirrhotic. Right. And you were like, would you? And I was like, I wouldn't have done this.
Right.
But
my attending
would, and I'm going to do what they want to do ultimately.
Right.
Like, cause obviously there's not necessarily a clear harm signal. It's insofar as excluding just the obvious, which is like a transfusion reaction. But I'm like, this is the way this attending likes to do it. We'll just do it this way. Right. Anyway, point of that story being is, and this and especially when you're early in your practice, right? Like a lot of times making decisions is hard. Yeah. Like, cause you're like, oh, so in this one, I felt pretty comfortable. I was like, let's just extubate. Anyway, our attending that was with me, I was filling her in later, not terribly long later, like within the hour. But as soon as I said it, her eyes got big and I was like, am I in trouble? And then she smiles and she goes, I like that. Yeah. I like that a lot. Cause I think she thought I was going to say, we need to go do a tube exchange. Yeah. I was like, no, we're not doing that.
Saved you from that.
Yeah. But, and I'm saying this too in the vein of like what we've talked about is trying to avert intubation. I had to go downstairs, see this other patient who had a pretty significant hemorrhagic stroke. Yeah. Extubated in the afternoon, needed some racemic. Anyway, when I saw her, I wish I had a better medical term for this appearance, but and you'll know what I'm saying when I say this patient was very neuro-y. Like and what I'm saying really is that while they're fairly intact, can follow commands appropriately speaking to you, obviously has residual neurological deficits, dysarthria, slowed speech, but they kind of have that characteristic, almost like poor head, neck, airway control. You know what I'm saying? So anyway,
some like bulbar stuff,
yeah,
obviously.
So yeah, kind of. So looking at that patient, I was like, and you know me, like I'm going to try to avoid an intubation at all costs. And I'm going to sidestep really quick and just make a note on that. And this is a cautionary tale to everybody. And when I was in ICU fellowship, when I was an ICU fellow, one of the things I was told, and I've referenced this before, we were trained really hard. You know what I mean? Like really hard, like you're tied to the whip and post kind of situation. So one of the things that I was told, and I am not saying that to you, the audience, one of the things that I was told was that if a patient fails extubation, it's your fault. And what they meant is, and this part I do believe in a little bit, is that whenever there's a patient who gets extubated, it is your job as a nurse to make sure they're up, they're coughing, they're deep breathing, they're ISing, they're acapella-ing, that you're working with RT, that you're communicating in real time if the patient is stridorous or maybe wheezing, maybe they need some neb treatments, whatever, that you're doing everything in your power to do that. Now, that being said, and this is why I'm saying this, there are patients that will fail regardless of you doing every single thing you can. So don't take every one of those things to heart.
No, and on that note, this has been we've talked about it. This has been talked about in multiple other critical care podcasts. So again, I can't quote you the study per se, but it's something around the line of if you're not reintubating up to like 15 or 20% of the patients that you extubate, then you're not being aggressive enough. You're not
trying hard enough
about your extubation practice. Because just as intubating somebody needs to have a cognitive pause, right? Or a thought on to, does this patient really need intubated? The same thing needs to be thought of leaving someone intubated, because once they're intubated, every minute, hour, day, shift, whatever you want to say, that we leave this patient intubated, we're exposing them to increased risk of prolonged hospital stay, increased length of ICU stay, increased risk of hospital-acquired infections, increased risk of ventilator-associated pneumonia. So
sarcopenia, poor functional status, like
so many. So, I in my practice have become much more aggressive about extubation as opposed to when I was in RT. Even I remember kind of the dogma of, oh, well, they passed SBT today, but they just didn't look that good. Right. So we're just waiting until tomorrow. I
hate that. I hate it.
Well, that's 24 hours, from a past SBT. Like, if anything, could we have not like left them on SBT settings, had them on some low dose Presidex, SBT'd again in the afternoon, got them off. Now, I know obviously we've gone through the PADIS guidelines, those types of things, like obviously getting that patient up, maybe even walking on the vent, those types of things, but we don't do that at our institution. But either way, you get the point.
Well, and there's even that, research, that recent research when they were talking about BID evaluations for extubation readiness.
Two SBTs.
Yeah. Oh, and also to answer your question from earlier, reintubation rate is 10 to 15%.
Okay. I said 15.
Yeah. So, and I say all this to bring this situation up because it highlights the fact that you can do everything right and the patient's still going to reintubate it. Now, we staved it off for 24 hours, and I'll just give you the brief. Like, I went down there, looked at this person. I've kind of described to you how they look. Now, she'll talk to me. She's not struggling to breathe. She's not tachypnic, no accessory muscle use. And she's only on like 2 or 3 liters, right? Yeah. So they had shot, I think we put in a gastric tube. So they had shot it. So I already had kind of a view of the lungs. And I was like, man, lungs don't look that bad. Like, lungs look pretty good. Air movement's great, like chest exertion, like everything. There's no restrictive, no obstruction, no infiltration that I can see. So pulled a gas because I was just like, let me see, maybe there's, some sort of mismatch here, right? So I look at that. PO2 is like 70, but everything else is okay. They're kind of alcoholic, so you can tell they're, breathing a little bit quicker, which they had told me that they were breathing in the 40s, but when I was seeing them, they were breathing in the 20s, which, vacillating, it can happen. So then in my head, I'm like, okay, what are my adjuncts, right? Sit up, make sure our airway is patent, NT suction if we have to. but again, PO2 of 70, right? So it's like not the worst in the world.
No, I'm fine with that.
Do I need to diurese? They're already in a negative fluid balance. So I'm like, not really. And they're alkalotic. So what am I going to do? Give Diamox? That's not really a rescue treatment, right? So what I landed on was high flow.
Yeah.
I was like, touch a PEEP.
Yeah.
You know, if there's an airway control issue, we won't risk BiPAP and, you know, doing all that jazz. Anyway, perked right back up, you know, everything. Now,
it's perfect for that patient.
Yeah. Now, that being said, 24 hours later, they ended up on 100% FiO2. I think it was an aspiration, you know, pneumonia kind of building situation.
Yeah.
So they did end up getting re-intubated.
Well, and I don't know.
But that's the show.
We're running long, and we can go down, you know, but I traditionally really struggle or have struggled in the past in the neuro ICU setting of patients who, because once they become intubated, right, unless they're having intervention and they're planning to have significant neurologic recovery within a couple of days, which is rarely, if ever the case, right? Like a status epilepticus, something, right? Like obviously you protect their airway, you'll be able to,
or mechanical things.
But
so
you know, in the setting of what you're saying, like with a bleed and all that kind of stuff, once they're intubated, the measures that we use to assess extubation readiness in the medical population are not nearly as applicable and easily performed in the neuro population, right? Like trying to ascertain, like, what if they're just having difficulty following commands? They can't lift their head. They've got a weak cough. They've got some bulbar symptoms. Their vent mechanics look fine, right? Because they don't have a pulmonary issue, but you're not sure about protective reflexes. And then I feel like in that setting, you know, then extubation gets put off because we're not sure. But what I argue for is we should still, again, move towards early extubation as a trial.
Yeah.
But again, in this setting, if they do fail extubation, knowing their neuro status and talking with your neuro colleagues and seeing what their expected recovery course looks like, then those are people that you should be more aggressive about pursuing early tracheostomy on, because if they're not able to protect their airway, but they have fine pulmonary mechanics, you know, I've had this discussion a lot with the nurses down there. I'm just giving this as something that I've improved on and learned on is, you know, intubating, extubating, re-intubating this patient 2 or 3 times is only being a detriment to the patient, prolonging their hospital stay, preventing them from getting to rehab and doing what they need to do to recover from their neurologic insult faster. Whereas if we just move forward with the trach, that doesn't inhibit. Now they're able to continue doing all those things. And hopefully they get decannulated in the future. But as opposed to the medical population where we may have a couple of try and fails as far as extubation goes, in the neuro population, more difficult to ascertain extubation readiness. And if they are requiring re-intubation, then I'm thinking much more aggressively about pursuing early tracheostomy.
Yeah, I would agree. And I would say this too, you know, obviously, you know, that I have a neurosurgical ICU, neuro ICU background. We extubate people that would make, you know, a MICU person's skin crawl.
Right. Exactly.
Where you're like, oh, you really, I'm like, yeah, 100%. And part of that is, and obviously there's always a component of the discussion that's about resource utilization, right? Like, do you have the staff to attend this person? It's like when you get asked, why don't you just extubate people at night? Because it's a risk. Yeah. It's not that I don't want to. It's that, one, the basis of that, which we talked about in the conference, is that every airway is a life-threatening issue, regardless of how many times you've been the operator, how many you've been a part of. Every one of them is that there's, especially at night, there's going to be a delay. If you have a super edematous airway, what if you get into like an ephonous situation? And I'm a mid-level. I can't cut the front of your neck.
Yeah.
Like, you know, I mean, I could, but I'll probably lose my license.
Yeah.
You know
Nor do
I
I want to.
Yeah.
Actually, I kind of do, but no, I don't.
But, you know, point being is that we don't want to take those risks unless they're absolutely necessary. Right. Now, have I extubated pissed off people at night? Yes, I have. Oh, yeah. You know, blown cuffs with good metrics? Sure. Yeah. You know, but that's not, none of those are decisions you make lightly.
Right.
That being said, with the neuro folks, you know, and I would say, like in this population, like in the case that I've just referenced, if you are doing all the basic components of care, aggressive bronchopulmonary hygiene, pneumonia prevention, all those things, sitting those people up, making sure that you're in T-suctioning, making sure that you're minimizing aspiration risk, yada, yada, yada. Like, your chance for successful, you know, remaining extubated is going to be very high.
I've got one good point to make, and then maybe we'll wrap this up. But we were talking about it. We didn't get into a lot of stuff that we were going to. I was going to talk about fluids because we love to talk about fluids. But something that I've been paying attention to myself and taking to heart is each of these little decisions that we make, we're arguing about or perseverating on.
I love that word, perseverating.
Thank you. It'll make up for the levetiracetam.
Yeah.
On minuscule things, right?
Mm-hmm.
But each individual thing in and of itself may seem inconsequential or minuscule.
Mm-hmm.
But if you stack on potential little insult, on potential little insult, on
mm-hmm. potential
little insult, now all of a sudden these seemingly inconsequential actions or decisions have now potentially changed your patient's course of care or prolongation of care. So, it seems nuanced. It seems a little draggy and annoying to
mm-hmm.
do all these airway things that you're talking about.
Yes.
Acapella. Do I have to do acapella and PEP and any percussion or NT suctioning and that type of things? But all of these little things inhibit a much bigger thing from happening.
Right.
And so just talk, because we do get pretty nuanced. If I'm choosing LR versus NS,
right,
that's a whole discussion in and of itself that's been outlined a long ways. And maybe you can make the argument, there's plenty of arguments to say that it doesn't matter. But if there's a signal of a potential difference, it's just a small thing, but it's another small thing in lieu of, should this patient get an art line or should they not?
Right.
Should I choose this vasopressor over this vasopressor? Yeah, it's academic and we're, debating these small changes, but let's say those little changes make a small difference that in and of itself wouldn't matter,
mm-hmm.
but you stack it on top of each other and now all of a sudden, you are making a difference in your patient's care.
I got Eric Thomas in my head right now. Greatness is a lot of small things done well.
That's what I'm talking about, baby. Come on. Come on.
Yeah.
So, take that away whenever you're angry or fretting over the mundane.
Yeah.
It's there for a reason.
Yeah. Well, and the last thing I'll say in regard to this is I understand that we sometimes extubate people on a chance.
Yeah.
Like on a chance that they'll do well. Just because they're doing poorly doesn't mean that you stop trying.
Well, and I can't quote you the statistics or data on this like you can, like in ultrasonography, right? They say that we've got the ultrasound with the auto EF and that kind of stuff,
mm-hmm.
but there's been good studies that in the hands of an experienced ultrasonographer, the gestalt of the clinician to say this is a mild, moderately, severely depressed EF is just as good, right? I would argue to say that there's that kind of, same thing in extubation readiness,
mm-hmm.
right? We have all these data points to look at. We have our SBI, SBT, tidal volume, saturations, tachypnea, tachycardia, those types of things.
Support
but sometimes you just, after doing it so long, you can just tell, right? You just have a feeling one way or the other. And I think there's something to be said about that.
No, I would 100% agree. And that's why, you and I are obviously both big proponents of, even though we do like getting caught up in the nuance, we're very big on saying, there's a lot of things that yield no benefits, so don't spend your time on it, right? So like there's a bunch of little things, and it's hard if you have a busy life and you don't have time to, watch things. But even if you look at every nursing assessment includes edema grading, right?
Yeah.
That portends nothing, which is why we don't do it anymore, right? Looking at an EF on a POCUS, right? Do I need to know whether it's 41% or 33%? No, I just need to know if it's reduced for the most part. And then I can do the rest of that workup. But so as we get on in time, is there anything else? I know you had more that we wanted to talk about, but now we're back. We're back,
baby. No, we've said it before. I feel like we gave fair warning in our previous episodes, knowing that it was going to be a difficult upcoming couple of months. I think it still ended up being more
difficult than we thought it would be.
Anticipated.
Well, and I forgot to mention, right? This is on the backbone of the critical care exam as well.
Right.
Like we were just.
Yeah. So there's been a lot of stuff that's been coming down the pipe. So hopefully back to regular scheduled programming.
Yeah. I've referenced this before, but I still have the Lost Kentucky tapes.
Oh God. Yeah.
I'm like, I don't even know if I can put that behind a paywall.
I think we should just keep that on a thumb drive for us for the future and not disclose it to anyone.
There was one.
We attempted to record when we were in Kentucky, but that went
Did I
downhill
ever
quickly.
send you, before you go to work, I have to show you some of the clips from it because I haven't uploaded because Riverside, and God bless Riverside. Since we've been doing this video, I don't really have to use it that often.
Yeah.
But we didn't do any video for that. So I was like, oh, I'll just put it in Riverside. That'll help me. It helps me chop it up a little bit easier, but it had an auto chop up and because it's updated and new and stuff. And there was one on there where it was us talking about the horse that we saw. You remember that? Yeah. It was not good. It was not good.
Oh, man.
So anyway, for old time's sakes, you want to walk us out?
Yeah. So you want to give your disclosure statement first?
Oh, I put it in video form.
Oh, you put it? Okay, you just got it. So
yeah, it's not a big deal.
That's been a unknown and unnamed episode of the Full Code Podcast.
Yeah.
We do appreciate you guys listening. I hope that we're still on your alert list whenever you
Dude, I've been getting threats.
Podcast.
I told you that, right?
Yeah.
I showed you when Dylan texted me.
We're continuing to carry on with our path that we're on. We'll work on, this was more of a discussionary based platform.
Yeah.
We do that a lot, but we'll come back with some more kind of like, educationally outlined material. We'll continue to have guests. We'll keep doing all the things we were before, just in a much more regimented fashion as we were kind of previously. We'll continue to try and put some stuff out on social media.
Yeah.
Make sure you're liking, subscribing, sharing with friends, family, anyone in the healthcare.
Get you some
critical care
merch, big
space.
dog.
Get you some merch.
Yeah.
It does help. It's a passion project. We love what we do. This has been fun being back. I missed it.
Yeah.
And we'll keep coming back at you guys.
Well, and good news, right? We are in, what is the evolving Full Code studio. You can see more of it on Clint's camera than mine. I'm just kind of facing up like, but we got you have a new computer. We're going to get you set up for Zoom so we can do the remote stuff. So we're not limited by that. We have the home studio here. Like we got a lot,
Ron had started putting out some like little shorts early on. Hopefully once I get something set up at home, I'll be able to do something similar. So in between like our long form podcast, if you call it that, we'll try and put out like little shorts, little tidbits, things like that. So
do some posing and some CrossFit
little
stuff.
Dr. Mike.
Yeah. So, anyway, so that's been the Full Code Podcast. Thanks for hanging in there with us, by the way. Everyone's been very patient. Minus Dylan, who threatened me.
All right, guys.
All right, see ya.